Dear students, Dr. Najib here. Today we are going to talk about number one, what is the morning stiffness which is associated with inflammatory arthritis, right? Number two, what is the clinical significance and importance of morning stiffness? What is the difference between morning stiffness and gelling, right? And of course, then I will discuss about the differential diagnosis of morning stiffness. I will give you some very important clinical points related with morning stiffness and rheumatoid arthritis, osteoarthritis, how to differentiate the morning stiffness of rheumatoid arthritis and osteoarthritis, then psoriatic arthritis, ankylosing spondylitis. Even we will discuss the morning stiffness present in the patients with polymyalgia rheumatica. Once we have done it, we will talk about the underlying pathophysiology of morning stiffness. So let's start our lecture. So what is morning stiffness? Morning stiffness is when person wakes up in the morning and person feels that there is loss of free movements of joints, right? When you wake up after sleep, when you wake up, you feel that there is loss of free movements of joints, or we can say that when patients wants to move his joints, the movements are slow and total range of movement is reduced, right? Usually morning stiffness is bilateral. For example, if the right hand patient is feeling stiffness in the right hand, patient will feel also stiffness in the left hand, right? So it is bilateral. In patients with the suppose polymyalgia rheumatica, if they are feeling stiffness in the right shoulder, they will feel the stiffness also in the left shoulder. So, and thirdly, morning stiffness gradually improves with the activity, right? We will talk about this thing when we talk about pathogenesis, why morning stiffness improves with activity. Now, before we go in further detail, we must know that what is the difference between the morning stiffness and gelling, right? As I mentioned, morning stiffness is for overnight sleep. When you wake up, you want to make activity by your joints, but you feel there is slow movements of the joints and the stiff movements of joint, and their total range of movement is reduced. But if during the daytime, if you remain inactive for prolonged period and you feel the same stiffness, that you are unable to move your joints freely and their joints range of movement is reduced, right? For example, you feel in the evening, and in the evening you have been inactive for couple of hours, but you have not been sleeping, and after 2 hours of inactivity, when you want to make your joints active, you want to make movements, and you feel there's stiffness and there's reduced range of movement, of course you cannot call in the evening that this is now morning stiffness. Now this stiffness will be called gelling. Gelling, gelling, right? So really, morning stiffness and gelling are not very different. The real difference is morning stiffness is of course in the morning after you wake up after sleep, and gelling is in the daytime whenever there are some periods of inactivity, prolonged inactivity, and after that joints display all the features of stiffness, right? So that then we will say that there is gelling. Now, I want to tell you something very important, that this morning stiffness is the hallmark of inflammatory arthritis. It's worth repeating. What is the clinical significance of morning stiffness? If patient comes with morning stiffness, for example, in his hands, and especially if it is associated with some constitutional features like low-grade fever or unexplained weight loss, or there's malaise, right? Or there is anorexia. With that, there is morning stiffness, which is last patient complains more than 6 weeks. You must think there is some inflammatory arthritis. Even though as doctors or medical persons, we study morning stiffness mostly in relationship to the rheumatoid arthritis, right? But actually, as I mentioned, remember that morning stiffness is feature of not only rheumatoid arthritis. It is not specific for rheumatoid arthritis. It is a feature of, yes, inflammatory arthritis. And you know, there are so many types of inflammatory arthritis. For example, rheumatoid arthritis is inflammatory arthritis. Osteoarthritis is, in a true sense, it is not inflammatory arthritis. Osteoarthritis is basically a degenerative condition, mostly involving the weight-bearing joint, like knees and hip joints or spine, or distal interphalangeal joints, which are of course not weight-bearing. But what I'm saying, osteoarthritis is not included in inflammatory arthritis. Why? The reason being, osteoarthritis is basically a degenerative disease which occurs due to wear and tear of most joints cartilage, and there is minimal inflammation. There's minimal inflammation in patients with osteoarthritis. So if someone asked that osteoarthritis is inflammatory arthritis, generally you should say no, it is a degenerative disease. But to be very, very specific, because even in osteoarthritis, there is damage to the cartilage and bones, right? And there is injury. And you know, wherever there is injury, in vascular tissue especially, wherever there is injury, there is inflammation. But this inflammation in osteoarthritis is minimal, very little, right? For example, in osteoarthritis, usually joints don't get red hot and swollen. They are just painful joints, right? But in true inflammatory conditions, for example, in rheumatoid arthritis, joints will become eventually red, hot, swollen, right? Now, here I want to say one thing, that in inflammatory arthritis, a very important feature is duration. Usually in inflammatory arthritis, morning stiffness is prolonged. Let me give you a scenario. If a person comes with osteoarthritis and another person comes with rheumatoid arthritis, it is possible that patient with osteoarthritis might have some degree of morning stiffness in his joints. But morning stiffness in osteoarthritis patient will be usually less than 30 minutes. It will be brief duration morning stiffness if it is present in osteoarthritis. Why it is short duration? Why it is short duration? The answer is very simple. That there is minimal inflammation. That is predominantly a degenerative disease with very, very little inflammation. So osteoarthritis usually does not have morning stiffness, or if it has, it is usually mild and usually for shorter duration, less than 30 minutes. But when we talk about that what kind of morning stiffness is associated truly with inflammatory arthritis, answer is morning stiffness. When the patient wakes up, it should last more than 1 hour. Morning stiffness lasting more than 1 hour and sometimes many hours. Right? And especially which improves with movement and activity. That is a hallmark of inflammatory arthritis. That is hallmark of inflammatory arthritis. So, another point is here that morning stiffness, which lasts more than 1 hour, not only it points towards inflammatory arthritis, but morning stiffness intensity and duration also is almost directly proportional to the underlying disease. For example, if a patient with rheumatoid arthritis has morning stiffness, when, as you know, in rheumatoid arthritis, there are remissions and relapses. Disease sometimes flares up, sometimes disease activity is reduced, or we say disease waxes, wanes and waxes. Actually, morning stiffness in the same way fluctuates. It means, for example, in patient with rheumatoid arthritis, morning stiffness duration and intensity will be proportional to the underlying disease activity. Right? Usually, what are the manifestations of morning stiffness? What patient will come to you and tell you? What patient will come and tell you that what has happened? Usually, patient will complain that in the morning, for example, if we think of a patient with rheumatoid arthritis with morning stiffness in his hands, right? Because in rheumatoid arthritis, very commonly small joints are involved, typically, right? Even though large joints can involve, but more commonly, more typically, small joints of hands and feet are involved, especially in the hands. You can say metacarpophalangeal joints, proximal interphalangeal joints, wrist joints. These are commonly involved in rheumatoid arthritis. And distal interphalangeal joints are usually spared in rheumatoid arthritis. But when patient comes to you, what he will say? Patient will say in the morning, if I want to make a fist, I cannot make fist. Or more commonly, he will say or she will say that I find it difficulty in dressing up or buttoning up, or difficulty in toothbrushing, or difficulty in face washing, or difficulty in combing, or if there's lady, maybe she complains the difficulty in wearing the jewelry, right? Or patient may complain there's difficulty in moving the knobs of doors or handles of doors or opening the jars. These are all manifestations of morning stiffness of hands, right? But remember, if it is rheumatoid arthritis or if it is any inflammatory arthritis, it will last longer and gradually it will improve with the activity, right? I will explain later. Actually, when hands do activity, the inflammatory mediators are washed away and that reduces inflammation to some degree, but it takes time. We will discuss this mechanism in detail later, right? But for example, if a patient comes to you with, and he is having underlying problem is polymyalgia rheumatica, right? The patient has polymyalgia rheumatica, their morning stiffness is not in hands. Their morning stiffness is in girdle muscles, in the shoulders, spine, upper spine, lower spine, hip joints, or muscles around the hip joint. In patients with polymyalgia rheumatica, right? Polymyalgia rheumatica, they don't have morning stiffness in hands. They are having morning stiffness in where? In the girdles. So this patient is not going to come and tell you that I cannot wash my face. This patient has a bigger problem. He says, I'm unable to get out of the bed. And let me tell you one thing. Sometimes you come across a patient with polymyalgia rheumatica where sometimes patient cannot come out of bed or roll out of the bed for many hours. But once they are up and about and gradually they increase their activity, after few hours, symptoms of morning stiffness may disappear totally. Right? So, whatever I was telling you, that morning stiffness is basically a hallmark of inflammatory arthritis. And here I would like to tell you one thing, that how do you define rheumatoid arthritis? And how do you differentiate rheumatoid arthritis and osteoarthritis? It's just some important point, right? One point I've already told you, rheumatoid arthritis is, yes, okay, let me ask you, Dr. Nazish, how do you define rheumatoid arthritis? Just try to define only in 2 words. Tell me 2 words, right, which are most important in defining rheumatoid arthritis. 2 or maximum 3 words. Or okay, just 2 words. Only 2 words, which if you say that or I say those 2 words, that strongly points to rheumatoid arthritis. Yes.
Autoimmune synovitis.
Excellent. Dr. Nazish, she has answered that this is autoimmune synovitis. Synovitis. Right? Basically, if I go into detail, the 2 words are autoimmune synovitis. But if we go in little detail, rheumatoid arthritis must be chronic, autoimmune, non-suppurative, proliferative, inflammatory synovitis. Now let me explain. Number 1, first of all, in rheumatoid arthritis, everyone knows it's a chronic disease with remitting and relapsing situation or fluctuating course. Number 2, everyone knows that rheumatoid arthritis is basically immune-mediated disease in which our own immune system attacks our synovial membrane primarily, right? Synovial membrane, actually in rheumatoid arthritis, some of our proteins are altered due to genetic predisposition and due to some environmental factors, right? And some lifestyle factors, right? We will discuss that in detail when we talk about pathogenesis. But what really happens, that some proteins in our body are altered. They are changed. How they are changed? That, for example, collagen type 2, which is found in hyaline cartilage, which is commonly in the synovial joints, or vimentin protein, this is a type of protein, or even fibrinogen. So what happens, type 2 collagen or vimentin or fibrinogen or some other proteins, they are altered, they are changed, right? Actually, what happens in these proteins, that there's one amino acid arginine that is post transcriptionally modified into citrulline. These protein, for example, collagen type 2 or vimentin or fibrinogen or in some other protein where amino acid arginine must be present. What should be present? Arginine, which is normally present, that is changed, that is altered, right, into what? Citrulline. So these altered peptide or proteins are called citrullinated peptides. So what really happens in rheumatoid arthritis patients, that many proteins present in synovial joints, right, they undergo alteration due to some genetic predisposition, like if patient has HLA, specific type of HLA alleles, for example, HLA-DR-B1, or patient is exposed to certain specific type of microbes. For example, one of them is Porphyromonas gingivalis, or due to patient's lifestyle, for example, smoking. All these factors somehow alter many proteins in our body in such a way that their arginine amino acid residues are converted into citrulline, and we call these modified proteins, that these proteins are having citrullinated peptides. Why am so much stressing on citrullinated peptide? The reason being that 70 to 80% of the patient with rheumatoid arthritis have anti-citrullinated antibodies. They have antibodies directed against modified peptides or proteins. Of course, these are autoantibodies. 70 to 80% of the rheumatoid arthritis patient have some serological marker of autoimmunity. Especially, we should think of rheumatoid factor. I will give a full lecture on rheumatoid factor later, and or anti-citrullinated antibodies, right? So this immune-mediated injuries start predominantly to the synovial joints, especially synovial membranes. And what happens to these synovial membranes? These synovial membranes, when they are injured by immune-mediated mechanism, right? I will not discuss in detail here because this lecture is about morning stiffness, but very briefly, many autoantibodies will attack there. Many immune cells will attack the synovial membrane. For example, T cells will be there, accumulating and proliferating. There will be B lymphocyte, which will convert into plasma cell. What is the real difference between B cell and plasma cell. B cell is usually inactive B lymphocyte. When B lymphocyte is activated and it starts producing antibodies, this activated B cell is called plasma cell. So next time someone asks what is plasma cell, you will say plasma cells are antibodies producing B cells, or simply say activated B cells. B cells are circular, spherical. Plasma cells are larger, and because they are producing a lot of antibodies and proteins, they have a big Golgi apparatus and other machinery for the peptide synthesis. So those cells, plasma cells, become oval and their nucleus is cartwheel shape. So what happens? In patients with rheumatoid arthritis, what was there? Peptides were, or proteins in the synovial membrane and cartilage were changed, right? Citrullinated peptides. Autoimmune reaction starts. Autoantibodies are there. Autoreactive lymphocytes are there, and many other than lymphocyte, many autoreactive inflammatory cells come over there. So this synovial membrane is, after the injury with the immune system, accumulates lot of T lymphocytes, lot of B lymphocytes, lot of active B lymphocytes, that is plasma cells, and of course all these cells, T cells and B cells, they are producing lot of chemical mediators and cytokines, chemical mediators of inflammation, including cytokines. So what happens? That local cells are also activated. What I mean by local cells? For example, mast cells will be activated. They will release they will degranulate their inflammatory mediators. From their membranes, inflammatory mediators like prostaglandins and leukotrienes will be released. Then synovial membrane cells, they undergo abnormal activation and abnormal proliferation. Normally, synovial membrane cells consist of two types of cell. Number one, they're type A cells, which are basically macrophage type cells. The synovial membrane, right, facing towards the joint cavity or facing towards the synovial fluid, it is lined by especially two cells normally. Number one, type A cells, which are macrophage-like cells, which are normally responsible that whatever little wear and tear occurs in the joints, they will phagocytose. Number two cells are type B cells, right? They are having characteristics of fibrocytes or fibroblast. Now, listen very carefully. Normal synovial membrane, on the joint where it faces the joint space, it is lined by macrophages, type cells, type A synoviocytes, and fibroblast type cells, the fibrocyte type cells, which are type B synoviocytes, right? Type A cells do phagocytosis of wear and tear products in the joint, and type B cells are producing hyaluronic acid and other proteins which play a role for lubrication in the joint. But remember, we don't say that synovial membrane is having epithelial lining. Please, this is very important. Synovial membrane normally does not have any epithelial lining. Even though I'm saying there is lining of synovial cells, but this lining of the macrophages type cells and fibroblast-like cells, they are not, we don't call them epithelial lining. You know why? There's a reason. There are rather two reasons. Number one, there are no junctional complexes in between the cells, which are characteristics of epithelial lining. And number two, synovial cells lining does not have basement membrane, which is another characteristic of epithelial lining. So what I'm saying, that when immune system attack, not only T cells, B cells, plasma cells, antibodies come over there, and of course antibodies activate the complements, T cells especially, and B cells, they can produce some cytokines, right? Then synoviocytes also undergo proliferation. Macrophage type cells, they increase in number. Fibroblast type cells, they also increase in number, and they become super active and abnormally active. So what is happening there? T cells are there, B cells are there, plasma cells are there, mast cells are activated, synovial cells are pathologically activated, they are over proliferating, they are overactive. So what will happen? That synovial cells, because they proliferate, we say there is a hyperplasia and a hypertrophy of synovial membrane in patients with rheumatoid arthritis. Hyperplasia and hypertrophy of synovial membrane. The real tragedy occurs that these local cells, which are supposed to protect the joint, they conspire with the immune system, and all of them start producing chemical mediators of inflammation and cytokine, right? So what happens? Over time, synovial membrane become over proliferated, over hypertrophied, with lot of inflammation and edema, with lot of inflammatory cells like T cells, B cells, plasma cells, lot of activated mast cells, lot of proliferated macrophage like synovial cells, lot of proliferated and accumulated fibroblast type inflammatory cells, synovial cells. All these cells are producing chemical mediators of inflammation, including the cytokines. Now this, of course, these chemical mediators, there are so many of them, but I want you to remember a few of them. Why? Because we have developed the drug against some of these cytokines, and we are using those drugs in rheumatoid arthritis, and they are reducing the action of these cytokines and helping us to reduce the problems of the rheumatoid arthritis patient, reducing the synovitis, right? So there are few cytokines which you should remember, every doctor should remember, which are too much increased in patients with autoimmune synovitis like rheumatoid arthritis. What are these cytokines? These cytokines, which are coming from the inflamed synovial membrane, number one, tumor necrotic factor. Now FDA has approved about 5 drugs to reduce the activity of tumor necrotic factor. Second, interleukin 1. Again, we have a drug to reduce the activity of interleukin 1. Third, interleukin 6. It is SIX6, not XEX. Interleukin 6. We have also drugs which reduce the activity of interleukin 6. Then interleukin 8. right? Interleukin 8 act as a chemokine, right, which attracts especially neutrophils. We have drugs for that also. So, and then another interleukin, which is very important, that is interleukin 17. Many doctors forget that is extremely important. Why? Because this interleukin 17 can activate the osteoclast and lead to the bone destruction, right? So, how many cytokines and chemokines you need to remember? At least there are so many, but minimum you should know, for which we are using therapeutic agents, right, which by way to treat the patient with rheumatoid arthritis. These drugs belong to the group of disease. They are called, the group of drugs are called DMARDs. DMARDS. What does it stand for? Disease modifying anti-rheumatic drugs. Now, this is a big group of drugs. They have revolutionized the treatment of patient with rheumatoid arthritis in last 2 to 3 decades, and many new drugs are coming. So there are subtypes of DMARDs, disease modifying anti-rheumatic drugs. Is that right? Now, these disease modifiers, how do they work? Many of them are working by reducing the either immune reaction or by reducing the product of the autoimmune reaction. For example, we have the drugs which reduce the activity of T cells. We have the drugs which reduce the activity of B cells, right? Again, I will repeat. We have the drugs which reduce the activity of T cells. There are drugs which reduce the activity of B cells. There are drugs which reduce the activity of tumor necrotic factors. There are drugs which can reduce the activity of interleukin 1. Then drugs reducing the activity of interleukin 6. Drugs reducing the activity of interleukin 8. Even drug reducing the activity of interleukin 17. So this is very important to understand that rheumatoid arthritis is a chronic disorder, right, with a fluctuating course, but overall, if you don't treat it, disease will become progressive. It principally attacks the joints, especially synovial membranes, and produces autoimmune synovitis, and that autoimmune synovitis ends up into accumulation of many immune and inflammatory cells in synovial membrane. There's accumulation of T cells, B cells, plasma cells. Then there are macrophages, neutrophils accumulated, right? Some macrophages are coming from the blood. Then local cells, for example, mast cells, type A synoviocytes, which are macrophages type cells, type B synoviocytes, which are basically fibroblast like cells. So what happens when synovial membrane become hypertrophied, hyperplastic, enlarged, loaded with lot of proliferated local cells and lot of accumulated inflammatory and immune cells and protein-rich edema, protein-rich exudate, and all this loaded with so much chemical mediators of inflammation and cytokines. This whole proliferated inflamed mass of synovial membrane is called Pannus. Please remember the spelling. This is not P-E. This is P-A-N-N-U-S. We call it Pannus formation. Right? So, again come back. What is rheumatoid arthritis if we properly explain it? This is a chronic autoimmune. Yes, this is chronic autoimmune mediated non-suppurative proliferative inflammation of synovial membranes. Now you know synovial membranes are not only present in synovial joints. Synovial membranes are present as synovial sheaths on tendons in hands and feet. Synovial membrane are present in the bursa. These are fluid-filled bags between the tendons and the bones. So what happens? When this immune process produces synovitis, it not only produces synovial joint synovial inflammation, it also produces inflammation of tendon sheaths in the hands and feet. This condition is called Tenosynovitis. And when immune process attacks bursa, we call bursitis. But remember, why I use the word that this inflammatory synovitis, which is resulting in synovial membrane inflammation and tenosynovitis and bursitis, why I say it is proliferative? I've already mentioned this inflammation is proliferative because many cells are proliferating there, especially many synovial cells, right? And why it is called non-suppurative inflammation? Because suppuration means pus formation. In these patients, even though there may be very severe inflammation, but there is no pus formation. In this autoimmune synovitis, when disease flares up, there may be very severe inflammation, but there might not be, of course, there is no pus formation if there is no secondary infection, right? So that is why we say this is a proliferative synovitis or proliferative inflammatory synovitis, but it is non-suppurative, no pus there, non-suppurative, right? So we came to reach to that rheumatoid arthritis is chronic autoimmune, yes, proliferative non-suppurative inflammatory synovitis, which manifests as synovial joint inflammation, tenosynovitis and bursitis. This is the very fundamental problem in patients with rheumatoid arthritis. But there is something, you know, even though rheumatoid arthritis principally attacks the joints, but in real sense, no tissue in the body is spared. We say there are extra-articular manifestations. But before I go for that, I will go back to that Pannus. That Pannus, the inflammatory, proliferated inflammatory mass of highly inflamed tissue. That Pannus is very dangerous because immune cells keep on superactive there. Chemical mediators are being produced, right? Pannus is enlarging. But what will happen? Because this Pannus is within the joint, it grows within the joint space, it will touch the cartilage and touch the cartilage and bone from the margin of the joint. Because synovial membrane is present in the inner side of capsule, but actually when it proliferates too much and it becomes inflamed too much and hypertrophied too much, it becomes pannus. It is loaded with inflammatory cells and it is loaded with chemical mediators and cytokines. First of all, it will produce a lot of problems within the joints. How? That this pannus, because it has a lot of, yes, another thing I should mention. You know the cells which are macrophages and cells which were there, fibroblast type cells, when they become so much injured and irritated and modified, they start producing metallic, yes, metalloproteinases, matrix metalloproteinases. What are matrix metalloproteinases? These are proteinases, mean protein digesting enzyme. They have some metals in that, but more important, metallic ions. But more important thing, they are able to digest matrix. Matrix mean connective tissue. Oh my God, this pannus is also loaded with matrix metalloproteinases, which are being produced by inflammatory cells, especially macrophages and modified fibroblast. Now, when this pannus will touch the cartilage at the margin, cartilage will be digested away. When they will touch the bone, wherever they will touch the bone chronically for a long time, they keep on pushing the proteolytic enzyme there. They will keep on pushing inflammatory mediators in that bone tissue. They will keep on pushing a lot of cytokines over there. You know what will happen? From the margin of the joint where pannus is doing its action, cartilage and bone will be eaten away. Not only by digestive process of destructive enzymes, but also due to activation of osteoclast, especially interleukin 17 and T helper 17. They play some role in activation of osteoclast. So, when you take the X-ray of the joint, because cartilage is being damaged, so cartilage thin out. When both ends of the joints, when cartilage become thin, we say there's narrowing of the joint space. Number one problem. Number two, where pannus is destroying the margins of the bone, right? On X-ray, you will find marginal erosions. Marginal erosions. Then, just under the cartilage, the bone which is just under the cartilage, we can call it subchondral cortical bone. That some subchondral cortical bone, because there is too many inflammatory mediators going over there and too much inflammatory cells are going over there, that will lead to high blood flow and that will wash away calcium from there. And at the top, so many osteoclasts are inappropriately overly activated. They are also destroying the bone. So what will happen there? Subchondral cortical bone, that area of the bone will show osteoporosis. We call it subcortical osteoporosis. These are three very important features in patient with rheumatoid arthritis These features are found radiologically. Narrowing of the joint space, marginal erosions, and subcortical osteoporosis. Here it reminds me of one thing. Even though most common cause of marginal erosions is rheumatoid arthritis, but good doctor know one more cause. There is one more disease in which marginal erosions are seen sometimes. Yes, who will tell me the name of that disease? Yes, Dr. Mariam, you are right. That is psoriatic arthritis. Psoriatic arthritis, this is also a type of inflammatory arthritis. This patient has usually, in 80% of these patients, initially develop skin and nails psoriasis changes, and many of these patients eventually develop psoriatic arthritis. Psoriatic arthritis, yes, they also produce marginal erosions. But classically, if someone asks you to tell the most common and most important disease producing marginal erosions, you will say rheumatoid arthritis. But if you want to be really too good, you say also in patients with psoriatic arthritis. Why? Because if there is psoriatic arthritis, in psoriatic arthritis, synovitis occur. That is why the marginal, what? Marginal erosions. But here I want to tell something more also about psoriatic arthritis. In psoriatic arthritis, on radiography or X-ray, you find a very special type of image. That image is called pencil in cup. Pencil in cup. Thanks God, they put a very decent name, right? Because one bone become concave, other bone become convex. That I will explain in how it happens. I will explain in psoriatic arthritis later. Yes, so what I'm saying, that rheumatoid arthritis can produce narrowing of the joint space, can produce marginal erosions, and can produce subcortical bone osteoporosis, right? These are three very important things. But marginal erosions can also be seen in some patients with psoriatic arthritis. Here is another thing I remember. You know, psoriatic arthritis and rheumatoid arthritis, of course, there are many points to differentiate. That in psoriatic arthritis, there is psoriasis, psoriatic changes in the skin. There can be evidence of psoriatic lesions in the nails, right? But there's another very important thing in psoriatic arthritis. You know what is that? They love to involve distal interphalangeal joints and less commonly proximal interphalangeal joint, least commonly metacarpophalangeal joint, and almost never wrist joint. But when you look at rheumatoid arthritis, in typical cases, rheumatoid arthritis patient, or the rheumatoid arthritis pathology, it loves to involve wrist joint, metacarpophalangeal joints, and proximal interphalangeal joint, and usually it spares the distal interphalangeal joints. So another difference between rheumatoid arthritis and psoriatic arthritis, both of them are inflammatory arthritis, both of them can produce morning stiffness, but in rheumatoid arthritis, we know that in typical cases, there is a tendency to involve small joints of hands and feet. In hands, especially rheumatoid arthritis process loves to involve wrist joints, proximal metacarpophalangeal joints and proximal interphalangeal joint, right? These joints are involved, but spares the distal interphalangeal joints. But when we talk about psoriatic arthritis, it loves to involve distal interphalangeal joint more commonly than other joints in hand. Another thing, because both of them are inflammatory arthritis and both of them produce morning stiffness, then we must know how to differentiate. So one difference I told you about the distal interphalangeal joint involvement in psoriatic arthritis. Secondly, in psoriatic arthritis, there are psoriatic changes in the skin and nails. Then I told you in psoriatic arthritis, on X-ray you can find pencil in cup radiological features, right? But marginal erosions are common to both rheumatoid arthritis and psoriatic arthritis. A very, very important clinical feature, I remember. Rheumatoid arthritis typically involves bilateral symmetrical involvement of joints. Both hands, similar joints involved. Thanks God, psoriatic arthritis involves less number of joints and it involves joints asymmetrical. Yes, in psoriatic arthritis, you may have more morning stiffness in one hand and less in other. But in rheumatoid arthritis, if there is morning stiffness in one hand, other must have. Right? From distal interphalangeal joint, it reminds me one more thing. I told you that distal interphalangeal joints are the target of psoriatic arthritis. But tell me, what is the most common arthritis which loves to attack the distal interphalangeal joint? That is osteoarthritis. You know, osteoarthritis loves to attack by degenerative wear and tear process with minimal inflammation, classically in weight-bearing joints like knees and hip. But if it involves hands, osteoarthritis loves to involve distal interphalangeal joints. But remember, now we say that psoriatic arthritis and osteoarthritis both are involving distal interphalangeal joints, but one is producing prolonged stiffness because psoriatic arthritis is inflammatory arthritis. Rheumatoid arthritis also produces prolonged inflammation, stiffness of the hands because it is inflammatory arthritis. But when there is osteoarthritis, it produces no morning stiffness if it does not involve hands, or it involves hands minimally, or if it involves hand joints significantly, osteoarthritis, it will produce minimal morning stiffness and only for shorter duration, which is usually less than 30 minutes, right? What are the other points where you can differentiate between the osteoarthritis and rheumatoid arthritis? But let me first go back. Let's go back to rheumatoid arthritis. We have only talked about that it is chronic, autoimmune, proliferative, non-suppurative synovitis. That is the major pathology. This disease predominantly principally attacks synovial joints. Usually small joints of hands and feet, right? Usually it involves small joints of hands and feet. I've mentioned already which joints. Morning stiffness is prolonged. But there is one more issue, that rheumatoid arthritis produces some constitutional features also. For example, rheumatoid arthritis disease typically start very insidiously. One of the earliest feature is morning stiffness and some joint pain, just arthralgia. In the beginning, there may not be arthritis. What is the difference between arthralgia and arthritis? Arthralgia means just joint is painful but not red, hot, and swollen. Right? That is arthralgia. But if joint is inflamed significantly and tissue around the joint is so inflamed that it feels red, hot, and swollen joint, we say there is arthritis. And of course, in rheumatoid arthritis, there is polyarthritis. Many joints are involved. Polyarthritis, symmetrical arthritis, dominantly small joints arthritis. Right? Now, I told you that rheumatoid arthritis produces some constitutional systemic features. For example, low-grade fever, unexplained or unintentional weight loss, anorexia, malaise. Malaise, what is malaise? Dr. David, what is malaise? Yes, malaise is feeling of being unwell. The patient really doesn't know what's wrong, but at least patients say, I'm not feeling well. That is malaise. So rheumatoid arthritis, because so much inflammatory process is going on in body and so many cytokines are being produced, and many of these cytokines, cytokines are actually protein molecules. Many of them have receptor, they go to the hypothalamus. You know, in the hypothalamus, blood-brain barrier is broken, right? So these cytokines can enter in central nervous system at the hypothalamus point, and by altering the function of hypothalamus, by producing more mediators there like PGE2, these cytokines, especially tumor necrotic factor, interleukin 1, interleukin 6, and many others, they alter the functions of hypothalamus, which result in constitutional features like low-grade fever, like weight loss, like malaise, like anorexia, right? These features are usually present at the initial time of rheumatoid arthritis. Then, extremely important thing, as I mentioned, that even though when we talk about rheumatoid arthritis and we teach about rheumatoid arthritis, we are talking about synovitis, but actually, many of these patients with rheumatoid arthritis develop extra-articular complications or features. For example, in patients with rheumatoid arthritis, they develop interstitial lung disease, pleuritis or pleural effusion, pericarditis, subcutaneous nodules. Here I would love to mention one thing. You know, all patients with rheumatoid arthritis who have joint manifestations, 70 to 80% are seropositive. What I mean by seropositive? That they are having rheumatoid factor or anti-CCP, anti-citrullinated, cyclic citrullinated peptide antibodies. Antibodies directed against citrullinated peptide, which I mentioned in the beginning. Those patients who are having rheumatoid factor or anti-citrullinated peptide antibodies, anti-cyclic citrullinated peptide antibodies, or both, we say they are seropositive. So 70 to 80% of the patients with rheumatoid arthritis are seropositive. But if a patient develops rheumatoid nodule, it is almost 100% cases seropositive. It means these autoantibodies have something to do with formation of extensor nodules, which are found in rheumatoid arthritis patient, subcutaneous nodules, right? Again, we come back. Patient with rheumatoid arthritis, they also have extra-articular manifestations. I mentioned pleural effusion, pleuritis, pericarditis, interstitial lung disease, pulmonary nodules, subcutaneous nodules, right? Episcleritis, scleritis, vasculitis, interstitial lung disease, and many more. Right? Question is, how these extra articular features are produced? When primary lesions are synovitis, I told you that these patients, they are having lot of autoantibodies, and those citrullinated peptides might be present in other tissues as well. Even though they are dominantly present in synovial membrane and joint tissue, right? This is one reason. Secondly, because autoantibodies are there and citrullinated peptides are also present in our body, so antigen-antibody complexes are formed. And these antigen-antibody complexes, they deposit in different tissues. Through circulation, they reach to different tissues. These immune complexes, wherever in the tissues they deposit, they activate the complements and call neutrophils and produce inflammatory lesions. So it means some sort of type 3 hypersensitivity reaction also occur. What is type 3 hypersensitivity reaction? In type 3 hypersensitivity reaction, antigen and antibodies make complexes, and these complexes, right, might deposit in different areas in the body and activate complements and other inflammatory cells and result into inflammation in those tissues. Right? Then many of these tissues are also damaged due to very high concentrations of cytokines. So it means when we talk about rheumatoid arthritis, we must talk about constitutional features like fever, weight loss, anorexia, malaise, and we must talk about articular features in which there is synovitis, damage to the articular cartilage, damage to the bone involved in the joint, right? Sometimes so severe inflammation occur, it damages the capsule, it damages the tendons, it damages the ligaments. All peri-articular tissue may be inflamed. Wow, it reminds me something interesting now. You know, in patients with rheumatoid arthritis, joints are swollen. And in osteoarthritis, joints are also swollen, but underlying mechanism is different. In rheumatoid arthritis, joints are swollen due to severe inflammatory process which involve the synovial membrane and even chemical mediator diffuse into periarticular tissue. So periarticular tissue inflammation. So joint in severe case of what is this? Rheumatoid arthritis become red hot swollen and of course painful. But in osteoarthritis, there is no severe inflammation. So joints are not red hot, but they are swollen. But that swelling in the osteoarthritis is not due to inflammation. That swelling is due to overgrowth of marginal bone, osteophytes. Now we are going towards another thing. X-ray differentiation or radiography differentiation between rheumatoid arthritis and osteoarthritis. But before we go for that, actually when osteoarthritis occurs, joints, cartilage undergo degeneration, wear and tear, and bones, margins, they overgrow and form marginal spurs or marginal growth, which are called osteophytes. These osteophytes may lead to swollen joint, but this is bony swelling. This is not soft tissue swelling like rheumatoid arthritis. So, if a patient has osteoarthritis, then distal interphalangeal joint will not be red hot. They will not be red hot, but they will be swollen due to osteophyte, and this will be bony swelling. This will be bony swelling and hard swelling. So joint will be swollen, joint will be hard and cool. Cool means it is not inflamed. It does not mean it's freezing. Cool means just body temperature. Just to differentiate, there is no significant inflammation. So in osteoarthritis, even if joint is swollen, this is a hard swelling. This is bony swelling. And with this bony swelling, what is there? No inflammation. Right? So we call it hard, cool swelling. If this is seen in distal interphalangeal joint and it is due to osteoarthritis, we give a special name to this swelling. What is the name of this swelling? Yes, distal interphalangeal joint undergoing the process of osteoarthritis. Joint is swollen, painful, but not red and hot, right? This is called Hubbardin nodule. Hubbardin, H-E-B-E-R, Hubbard, D-O-N, Hubbardin's nodes or nodule, Hubbardin nodes. And if similar swelling is present in, okay, this is Hubbardin's node. But if there is rheumatoid arthritis process, then joint will become, of course, it will be enlarged. It will be enlarged, but it will be red and hot. And if you touch it, palpate it, it will not be bony hard. It might be soft, spongy, tender, right? Due to underlying severe inflammatory process of soft tissue as well, right? So what did I say? In degenerative disease like osteoarthritis, joint will become swollen, joint will become painful, but not red hot, right? But not red hot. In rheumatoid arthritis, joint will be painful, joint will be swollen, but it will be also red and hot. So if you have a hot nodule, hot and soft joint enlargement, and multiple joints symmetrically, think of small joints, especially think of rheumatoid arthritis, right? Let's differentiate on X-ray also the difference between osteoarthritis and rheumatoid arthritis. First of all, common thing. In rheumatoid arthritis, synovial joint is lined by which cartilage? Hyaline cartilage. In rheumatoid arthritis, inflammatory process and inflammatory products are digesting away the hyaline cartilage. So hyaline cartilage become thin and joint space become narrow in rheumatoid arthritis. But if you look at the X-ray of osteoarthritis patient, there also you find narrow joint space. But mechanism is different. Even though there is also thinning of the hyaline cartilage, but this thinning is due to wear and tear process, mechanical breakdown of cartilage with impaired healing with minimal inflammation. So radiographic changes in rheumatoid arthritis and osteoarthritis, one thing is common, both of them will have narrow joint space. But here similarities begin and here similarities end. In rheumatoid arthritis, I told you there is inflammatory pannus formed due to proliferative and inflammatory and hyperplastic changes in pannus. They were producing marginal erosions. Marginal bone was eaten up as a rat has been nibbling at the margins of the bone. In rheumatoid arthritis, radiographically you can identify erosions, marginal erosions. But in case of osteoarthritis, there is no pannus. There is no severe inflammation. So there are no marginal erosions. Rather, due to abnormal repair effort by subcortical bone, marginal bone makes outgrowths or spurs or osteophytes. So rather than marginal erosions, where in rheumatoid arthritis in marginal erosion, margins of the bone are eaten up by the nibbled out. In case of osteoarthritis, margins are having osteophytes abnormally expanding in radiograph, right? Third thing, another change. I told you in rheumatoid arthritis, subcortical bone was showing osteoporosis, right? Because there's too much osteoclastic activity under the direction of inflammatory cytokines. But because in case of osteoarthritis, there is abnormal mechanical pressure on the subcortical bone or subchondral bone due to wear and tear process. When cartilage is being damaged, subcortical bone try to do some excessive bone production. This excessive bone production is to provide extra support to the joint, and subcortical sclerosis will be seen. Subcortical sclerosis will be seen. So if I say narrow joint space plus marginal erosions plus subchondral osteoporosis, and these changes are in multiple joints and symmetrically, think of rheumatoid arthritis. But if joint space is reduced, marginal growth are seen, osteophytes, and subcortical bone is excessive, there is sclerosis, think of osteoarthritis. I think this is also worth mentioning that rheumatoid arthritis is, like many autoimmune diseases, more common in women, right? And most of the cases are diagnosed between 30 to 50 years of age. But osteoarthritis, this disease is usually related with aging and obesity, right? So in later age, its prevalence keep on increasing in population, osteoarthritis. Another thing, do you think osteoarthritis should have constitutional features like rheumatoid arthritis? No, because in rheumatoid arthritis, so many inflammatory cytokines are being produced, but such inflammatory process is not happening in osteoarthritis. Then, in osteoarthritis, of course, there are no constitutional features, no low-grade fever, no significant weight loss or unintentional weight loss, or there is no malaise or anorexia, but of course, painful joints significantly reduce quality of life. And as we mentioned, that rheumatoid arthritis has multi-systemic manifestations, or just we call it systemic manifestations, as I told you, pneumonitis, interstitial pneumonitis, or pleuritis, pericarditis, scleritis, vasculitis, subcutaneous nodule. Do you think such thing will be present in osteoarthritis? No, because osteoarthritis is not an immune-mediated disease, and there are no immune complexes wandering in the blood and depositing in different tissues. So we say manifestations of osteoarthritis are mostly limited to the weight-bearing joint and in the hands, usually in distal interphalangeal joint. Right? So now we have discussed that what is morning stiffness, right? What is morning stiffness and what is the pathophysiology of morning stiffness, we'll discuss in next lecture, right? Then we have also discussed what is the difference between morning stiffness and gelling. We have discussed something about the rheumatoid arthritis and osteoarthritis and how to differentiate them and underlying problems, right? Rheumatoid arthritis and osteoarthritis. Then I will repeat it. If morning stiffness is more than 1 hour, think of inflammatory joint disease, inflammatory arthritis, right? What we discussed today, especially inflammatory diseases, rheumatoid arthritis and psoriatic arthritis, right? And just to compare, we discussed about osteoarthritis, which is not primarily an inflammatory arthritis, that is basically degenerative arthritis with minimal inflammatory condition, right? Then we discussed about, yes. Okay, before I close, I also discuss about this ankylosing spondylitis. Ankylosing spondylitis is one of the autoimmune diseases which is more common in males. It is associated with HLA-B27. It classically involves sacroiliac joint. Sacroiliac joint, part of a joint is synovial, right? So here immune process attack the sacroiliac joint and also attack the spine joints. And also involve the spine joints, But what is the relationship of ankylosing spondylitis with morning stiffness? Yes, there is. Usually these are young boys, right, who suffer with this disease, unfortunately, and they start developing lower back pain. This is due to inflammation of sacroiliac joints and inflammation of spine joints, right? With this pain, they develop morning stiffness in, yes, where? Morning stiffness in pelvis and lower spine. And when in the morning they wake up, it is very difficult in severe cases to come out of the bed. But the beauty of this disease is, there's only one beauty, unfortunately. As they become active, and especially they do exercise, then their pain keep on decreasing and sometimes even disappears. An ankylosing spondylitis, which is HLA-B27 associated disease, autoimmune disease, classically produces sacroiliitis, immune-mediated damage, and also to the spine. And with the time, this is also progressive, right? And it produces what problem? It produces spine stiffness. Spine becomes stiff and it loses its normal curvature, right? But the morning stiffness is when these young boys, when they wake up, they have lower back pain and stiffness and very difficult to move lower part of the body. But as they, with some effort, as they do make the movements, with the time, even though it takes more than 1 hour, eventually that pain subsides, right? So now we have discussed that morning stiffness is a feature of inflammatory arthritis. If both hands are involved, right, symmetrically, proximal interphalangeal joints, metacarpophalangeal joints, even wrist joints, think of rheumatoid arthritis. If one hand is involved more than the other hand and there are psoriatic changes in the skin and nails, think of psoriatic arthritis. If there is morning stiffness in lower back and with movement it improves, especially in the boys, think of ankylosing spondylitis. Usually it's a disease in younger patient. And if you find someone which is almost always more than 50 years old and having morning stiffness in upper and lower girdle muscles and joints, that is shoulder joints and spine and hip joints, all of these, when you wake up, you find all these girdle muscles and joints are stiff, very difficult to move, reduced range of movement. Age is more than 50 years. Think of polymyalgia rheumatica. Think of polymyalgia rheumatica. You need to rule out this condition. Right? So how many conditions we discussed? Rheumatoid arthritis as inflammatory arthritis. Osteoarthritis as degenerative arthritis with minimal inflammation, but how to differentiate from rheumatoid arthritis. Third, we discussed psoriatic arthritis. Fourth, we discussed ankylosing spondylitis and morning stiffness. And in the end, few words about morning stiffness in polymyalgia rheumatica. A very brief review. Morning stiffness, both hands, symmetrical small joints, constitutional features, more than 6 weeks, red hot swollen joint, think of rheumatoid arthritis. Weight bearing joints, so distal interphalangeal joints, swollen, bony, hard, swollen like and bony and hard and cool. Think of osteoarthritis. Lower back stiffened in the morning. With the movement, it improves, especially in boys, more common. Exercise is a very good treatment and act as a management and treatment protocol. Think of ankylosing spondylitis. Then morning stiffness, upper girdle and lower girdle, age more than 50 years. Think of polymyalgia rheumatica. Right? I did not talk about its pathophysiology. Remember, I did not discuss even rheumatoid arthritis per se as a disease. Right? Because if you talk about disease, then you have to talk about that what kind of deformities will form, because this disease is progressive if not treated well. What kind, and eventually joints deformities occurs, even sometimes bones become fused, ankylosis occur. We did not discuss. We were just discussing these diseases in reference to morning stiffness. Morning stiffness. So arthritis is left. And then if there is asymmetric morning stiffness, and especially in distal interphalangeal joints, and some skin lesions and nail lesions, think of psoriatic arthritis. Right? Now I ask you one question. Yes, now my turn. My question is, if there is red hot swollen very painful joint, red hot swollen very painful joint with overlying erythema, think of, yes, it is your turn to tell me, red hot swollen very painful joint with overlying erythema, think of septic arthritis. Or think of crystal-induced arthritis. Crystal-induced arthritis like gout or pseudo-gout. Right? Yes. Now, in the next lecture, we will discuss in detail about what is the pathophysiology of morning stiffness and why morning stiffness improves on activity or movements eventually, and why in the daytime in patients with the morning stiffness, if they remain inactive for prolonged time, joints again become stiff. That is gelling, G-E-L-L-I-N-G, gelling from the gel. Why gelling occurs? So this pathophysiology of morning stiffness and how it resolves on activity, and why certain drugs which are anti-cytokine are used in these conditions, we are going to discuss in the next part. Thank you very much for listening to me. Best of luck.